So I'm going to also give the next presentation. So the next presentation that I'm going to give is about hepatocellular carcinoma. And so I made a decision that I don't think that people in this room really want me to talk about LIRADS, like to really jam home LIRADS, because I think it's beyond what we're doing. And I think it's more the relationship of the LIRADS to CUS is what I think is most important. So that's what we'll try to do. So this talk I entitled CUS LIRADS 5 and LIRADS M. Do they look after HCC and cholangiocarcinoma? Now, so hepatocellular carcinoma, which I abbreviate HCC, is a primary cancer of the hepatocytes. And today, it's the only solid organ cancer with increasing incidence in North America. Now, cholangiocarcinoma, which we abbreviate ICC, is found in the same population in that it is at increased risk of development also in patients that have hepatitis B, hepatitis C, and cirrhosis of any cause. And so they all have increased risk for both HCC and ICC. So therefore, we want to recognize that the risk for developing cholangiocarcinoma overlaps with the risk factors for HCC. And we recognize, of course, that HCC will be many, many, many times more common than will ICC. So let's look at some American cancer statistics. So if we look at the death at the interval from 2003 to 2012 and look at cancer death rates. So in North America, these death rates have declined for women, for men, and for children. Now, when we look at specific cancers, though, however, this is what we find. So all of the cancers that are at the bottom that have the turquoise bars going out to the left, those are cancers that have got a decreased incidence. And the cancers at the top that go out to the right in men and in women, those represent the top line is the liver and the biliary ducts, and in women also the liver and the biliary ducts. So in the interval when the liver cancer and biliary duct cancers have been increasing wildly in North America, all those other cancers, that includes colorectal cancer, prostate cancer, breast, and lung. So all of those big cancers have shown a decreased death rate. Now, so what's the importance about this? Well, first of all, or why did this happen? That would be a good question. So one of the major explanations for why this happens is related to the obesity epidemic and to the problems with diabetes and metabolic syndrome. So certainly obesity is increasing in our country. And with that, of course, is that marked increased incidence of fatty liver. And so NASH and NAFLD are thought to be on the verge of becoming the most common explanation for chronic liver disease and the development of HCC in North America. And so this makes something that really, for radiologists, this has really rung a bell. And so, of course, I'm sure that all of you who are in radiology department know there are many people who have devoted their careers really to liver imaging with CT and with MR. And so recently, there's been a whole group of us who've become enthusiastic about this for CUS as well. And so one of the things that's happened is that there's been this development with an ACR-sanctioned process called the LIRADS. And so this stands for the Liver Imaging Reporting and Data System. And so what this does is it provides an ordinal risk classification system for observations that are made on liver imaging in patients who are at high risk for developing HCC or HCC and ICC. And the vast majority of malignant tumors that arise within the cirrhotic liver are of hepatocellular origin and can be classified with LIRADS according to a probabilistic scale from LR1, where we don't think that they're HCC, to LR5. Now, non-HCC malignancies, so this would be the cholangiocarcinomas, they deviate from this ordinal approach and may best be considered lateral to LR5 in terms of probability of malignancy. So this is actually the version 2016 algorithm for LIRADS. And I've left this in here because we did a validation study of LIRADS in my own institution. And when we started, it was just at the beginning of 2017. So there was no other version, and this is what we used, and I'm going to refer to it as I go through this presentation. But so LIRADS was first developed and published on the ACR website for CT and MR scan. And the LIRADS for CUS is new. And so, of course, the fact that we have LIRADS for CUS is a great benefit for us in that now it's becoming more commonplace knowledge amongst our colleagues and our friends in CT and MR scan that CUS LIRADS is part of this multidisciplinary approach to the diagnosis. So if we look at this algorithm, I'm sorry that my mouse doesn't seem to work on here, but you can see we're talking about observations that we make on the scans. So on the top bar, over to the left, it says LR, non-diagnostic. So if you have a non-diagnostic scan, you have to put it in there and say that the patient needs other imaging. But then when we come across, we come into LR1 and LR2, and then LR5V, which is now called LR tumor in vein instead of 5V. And then at the bottom, we have this nice box, which is our diagnostic box, and it includes the nodules that we believe develop by hepatocarcinogenesis. And you can see that when we look at this box at the bottom, it includes information about the size of the nodule, the enhancement of the nodule in the arterial phase, and then whether or not it washes out. And so, of course, we come out in the end with this very important box at the bottom, which is LR5V. And so LR5V is a box that is going to allow us to have non-invasive, confident diagnosis of HCC. Now, in addition to that, we have to consider validation. So what was our objective in our validation study? Well, the overwhelming objective in looking at LIRADS is to maintain the specificity for HCC approaching 100%. And this is mandated by most major societies. In other words, if you say that you're looking at the mass on a contrast ultrasound or CT or MR, and you say, we think this is LR5, well, they want you to be virtually 100% of the time correct. So they don't want you to be wrong. And so they want you to have very high specificity. So why do they want this? Well, this will allow diagnosis and treatment of HCC based on imaging characteristics without the necessity for tissue diagnosis. And so then in addition to that LR5, which is so important, there's LRM. And so LRM has a very, very unusual description in that it says it's definitely or probably malignant. And I remember when someone told me that, I thought, I don't think you can be definite or probable in the same sentence. But anyways, I lived with it for a while, and now I think I figured it out, and I'm going to show you why. So what is this LIRADS 5 category? So it's a category that we want to serve as a reference standard that negates the need for pathologic proof. And the algorithm is designed to emphasize positive predictive value and specificity over sensitivity for diagnosis of HCC. So the goal is 100% specificity, so no false positives. So it doesn't matter if you have an HCC that you don't put into LR5, but what does matter is if you have something that's not HCC that you do put in. So they don't want people going for transplant and going for aggressive surgery that don't have HCC. And if you miss some of them, I'll show you what happens to them. So when we have this very stringent requirement of 100% specificity, this provides substantial specificity for the diagnosis. So what are these criteria? So first of all, the size should be over 1 centimeter. In the arterial phase, we should show hyperenhancement. So arterial phase hyperenhancement, like I've shown you already today. And then in the portal venous late phase, we want to show slow and weak washout at greater than 1 minute. So let's look at a surveillance scan. So this is a 64-year-old male with HCV cirrhosis, and his surveillance scan reports 2 nodules. So the first one is there between the branches of his portal vein. So we do contrast enhanced ultrasound, and so we watch the contrast come in as I've shown you before. So we record to just beyond the peak of the arterial phase. So there we can see that this is definitely a hyperenhancing nodule. So it has APHE, it's over 1 centimeter, and then when we watch at 90 seconds, it's got weak washout, which is later than 1 minute, and so this is LR5. Now what about, and then when we keep watching, we see marked washout. So we always want to classify the washout on the basis of its appearance when we first see it, not later when it's become more marked. Now, what about the second nodule? Well, this is a much smaller nodule, but it measures about 1 centimeter. So when we look at it in the arterial phase, we can confirm easily that it also shows arterial phase hyperenhancement. And then again, right at the same time, 90 seconds late weak washout, which also becomes more marked by the time we watch to 4.5 minutes. So 2 nodules that are both LR5. So this patient can go on to whatever kind of treatment they choose. In this case, it was ablation therapy, and this patient has both nodules ablated without requirement for prior tissue biopsy. And what does this show us? It shows us that, yes, you can certainly evaluate more than 1 nodule on CUS. That's always a big criticism, that we can only do 1 nodule on this scan. So now what about this other patient? Another patient with a nodule that's hyperenhancing in the arterial phase, a bigger nodule. And so we take our images that allow us to fulfill the criteria. So we have pictures at 1 minute, which shows that the mass shows still sustained enhancement. And then by the time we get to 2 minutes and 30 seconds, it's still showing sustained enhancement. But perhaps at 3 minutes and 30 seconds, it's just starting to go down. And by 4 minutes and 30 seconds, there's definitely late weak washout. So from this, what do we learn? We learn that we have to watch for a long time. As long as there's good enhancement of the liver, you want to keep watching. And so certainly in our department, we watch always for 5 minutes and oftentimes considerably more. But so this is, again, a classic HCC. So stronger washout at HCC at 5 minutes. Now, so when we're considering the rules for LR5, the criteria that emphasize specificity by necessity will reduce the sensitivity. And so as such, there will be many HCC which will not meet these stringent criteria for LR5. And so where will they go? Well, they'll mostly end up in either LR4 or LRM, the closest categories to LR5, or they may be all the way back to LR3. But regardless, all of those categories will have follow-up imaging, and some will recommend biopsy. And this is such an example. So this is a 79-year-old male with HBV cirrhosis. He has an exophytic nodule in his liver that shows APHE in the arterial phase. At 2 minutes, it's still hyperenhanced, and at 4 minutes, it's still hyperenhanced, and it never showed any washout. So this nodule is about 2 centimeters in size. It was concerning to me. I thought it was new. We hadn't seen it before. So we pushed them then to biopsy this, and this is an LR4 that turns out to be an HCC, which is fine. It's okay if the HCC goes somewhere else. What's not fine is for something else to go into LR5. So this was the case I showed you before. So this is the hepatoma surveillance lady who has got this small mass in her liver. And this was the mass that is the classic flash-filling hemangioma. So we can see that it's a hyperenhancing mass, and it's hyperenhancing all the way through at 1 minute and at 4 minutes. And so this is a flash-filling hemangioma. So it goes in LR1 and doesn't need anything more. So that's fine for that. Now, what about LRM? So LRM refers to something that's either definite or probable malignancy without specificity for HCC. And so what are the criteria for LRM? Well, they include arterial phase, any one of these, not all 3. So the LR5 criteria, you need all of them, and here you need just any one. So arterial phase rim enhancement, rapid washout at less than 1 minute, or marked washout showing as a punched out hole at first observation. So LRM, unlike other algorithms for HCC, LIRADS provides a category for lesions that are definitely or probably malignant, but not specific for HCC. And so this allows us to preserve the specificity for the HCC diagnosis while maintaining a reasonably high sensitivity for the detection of malignancy and appropriately directing care in patients with those malignancies. So let's look at such a patient. So this is a 78-year-old male with a normal liver, and he has hepatitis B surface antigen positivity. So he has a nodule found on surveillance on ultrasound in 2013. So this is not my scan, it came from outside. But an MR scan was performed after he had the positive surveillance scan, and it shows this enhancing nodule of very small size up by his diaphragm. And so it was interpreted as possibly a hemangioma, not really with a strong confidence level, and the patient disappeared, unfortunately, for 2 years. So when the patient comes back, the surveillance ultrasound performed in the same place said it's growing, so then they send it back for another urgent MR scan. So now on the T1 Vibe, you can see a low signal intensity mass in the liver corresponding to the same location. And when we look at this mass on the post-gadolinium images, you can see that the mass enhances, and then the mass does not show any washout. And so, of course, this could be a lot of different things, but could be a cholangiocarcinoma. But so when the patient comes to us, you can see this hypoechoic mass in the subdiaphragmatic region. And so although I said to you before, we don't usually do full inspiration, this is a full inspiration scan. And you can see that the mass is hyper-enhancing, so it's in agreement with the MR scan here. But here we can see that very early we see washout. So by 30 seconds, we see that there's some weak washout, which gets stronger. So this is, again, that picture that we had before, where we have washout on ultrasound, and we have increased or sustained enhancement on MR scan. And so here's another patient, 67-year-old female with HCV, mass on outside ultrasound, and she comes for a CT scan. So I think that this is a fairly difficult CT scan. But so there's her baseline and her arterial and later scan. And you can see that she's got rim enhancement, which is quite nodular. And then when we look on her MRI, we see the same features as on the CT scan, with that rim with central nodular components and no evidence of washout. And so both of these are somewhat indeterminate, and this patient also has a mass, an echogenic mass in the subdiaphragmatic region this time, and this patient has a big full inspiration, but we can still get a good ultrasound, and there we can see that this mass is rim enhancing on CUS, and that it shows rapid washout by less than 30 seconds. And so this is LRM for us, and this is showing again that discordance between ultrasound and MR scan. And so this lesion was biopsied, and so both of these lesions, the last two that I've shown you, are cholangiocarcinoma. And so for those of you who, I know you ladies will know this, certainly the AASLD guidelines holding back on ever having CUS involved is related to their belief that we don't diagnose cholangiocarcinoma, whereas I believe, of course, what else would anybody expect? I believe, and I think everybody in my department, my clinicians say to me always, Stephanie, you're the first one always that says this is going to be cholangiocarcinoma. We say it all the time. So that's what I think. And so rapid washout on CUS and increasing enhancement or sustained enhancement on MR CT scan. And that's the discordance that's characteristic. And so this is where this beautiful schematic I showed you this morning actually first showed up in my talk. But so that shows the pseudo enhancement that comes from the interstitial contrast on CT and MR, whereas our intravascular microbubbles allow us to show true washout in that malignant situation. And so the histology of these tumors is that they're usually tumors with peripheral cellularity with central fibrotic stroma. So on MR, pseudo-enhancement, on CUS, APHE, and washout. Now, what about combined tumors? So there's tumors that are called hepatocholangiocarcinomas. And so if we look at their imaging features on MR and on CUS, they can be either. They can look like cholangiomas and they can look like HCC, although there's more of a tendency for them to look like cholangiocarcinoma. Now, when we come back to this question about the LRM definitely or probably malignant, and so my question always was, how can it be definitely and probably? And so I'm still not sure, but I have some astonishing cases that help me to manage this. So this is a 45-year-old male, Filipino, asymptomatic, and he's an HBV carrier. So when we look at this, you can see that he's got a very fatty liver and he's got black masses in his liver. So the scan looks concerning. I'm looking at it, I think, oh my goodness, I'm concerned. So then when we do the contrast injection, you can see that the mass is in fact enhancing. And although it's not striking, it still is mildly hyper-enhanced relative to the liver. And then there you can see already that it's starting to wash. So there's his mild APHE. And then when we look at less than a minute, those black masses are back to completely black. So what am I going to say? Rapid washout. I'm worried about this. Biopsy it. And so they do, what is this? At-risk patient, big masses, APHE, rapid washout, called malignant on CUS and CT and MR scan. So there's a clue. It's not discordant. We all agree it's malignant. So we all say it's malignant. So when we biopsy those, almost without exception, inflammatory pseudotumor is the thing that comes up a lot. And so the fact that they're not discordant makes me feel that it's not likely going to be cholangio. So what about this great case? This is a 64-year-old male with HBV cirrhosis, and he has a biliary stent, which I'm not sure about why he has that. In any case, he presents with severe right-sided flank pain, and he's got this very unusual mass in his liver, which seems to involve the liver capsule. So it's mixed echogenicity. So I don't know what it is, so we do contrast. So when we do the contrast injection, it's really a beautiful scan. So there's a hyper-enhancing mass with black holes inside. And then as we're watching again, now we're only very, very early on in the imaging, you can see that it was hyper-enhancing, and now it shows that rapid washout. And so when we do another scan at 3 minutes, you can see now it's a great big huge washout hole, and it seems to involve all the soft tissues of his body wall as well. So anybody want to guess what this one is? So arterial phase hyperenhancement, some small cystic areas within, rapid washout, and then incredible late phase washout seemingly involving the abdominal wall. And so again, this is LRM to me. She's a risk patient, and it's not discordant with CT. It agrees with CT, malignant enhancement, biopsy, and this is IgG4 pseudotumor. And so those, if you call everything LRM that has that pattern, you find that sometimes you're wrong because it turns out to be particularly inflammatory masses. So now I've learned it over time. So when I come to LRM, I'm a little bit different. So when I come to LR5, I say, this is LR5, this is HCC. But when it comes to LRM, I say, this is a malignant enhancement pattern. This is generally associated with a non-hepatocellular malignancy, although occasionally other diagnoses may fall in this category. Because otherwise, my hepatologist would say to me, Stephanie, you were wrong, and the MR guys were wrong, and the CT guys were wrong. And I said, well, we weren't exactly wrong. We just didn't get the right diagnosis. And so now I cover myself better by saying a malignant enhancement pattern that can include more than just non-HCC malignancy. So in this talk right now, we did not talk about hepatocarcinogenesis. We didn't talk about the spectrum of nodules that we see in routine daily practice or the unbelievable spectrum of appearances that we can see for HCC. We didn't talk about nodule and we didn't talk about all kinds of things, but we did talk about HCC and ICC and their relative and really significant importance. So then we did a validation study. So this was a single center study that was done at the University of Calgary. So we did a retrospective analysis of nodules over several years, and then we put them into a blind read format, and we had a 3-person blind read. And all of the blind readers are members of the CUS LIRADS committee. And so we had 139 nodules that were HCC by histopathology, 18 non-HCC malignancy, by histopathology, and 39 benign, 3 by histopathology, and 36 by long-term stability and follow-up. And so so the 2 false positive cases that ended up in LR5 include 1 cholangiocarcinoma. So that 1 cholangiocarcinoma I've reviewed, I've shown it to everybody, and it's a nodule. It's about 2.5 centimeters in size. It shows APHE and it shows late week washout. It's called LR5 on MR scan as well. And in retrospect, and if I saw it again, I would call it LR5. So we had 1 false positive case. We also had 1 mixed HCC cholangiocarcinoma, and it has LR5 characteristics on both ultrasound and MR scan. So that was very good. We met our objectives in that. Our specificity for LR5, we put one ICC and 1 mixed tumor, and otherwise we had 98 correct HCC for a specificity of 97%. Now, when we come to LRM, there were 26 cases that we categorized as LRM. 16 of them were non-HCC malignancies. And so these include 6 metastases, 8 cholangiocarcinoma, 1 lymphoma, and 1 PEComa. And it includes additionally 9 HCC. So the HCC end up in there, but because we're going to biopsy them all, they're going to get picked up anyways. So 9 HCCs. And so when we looked at those 9 HCCs, what made them go into LRM? In 8 of the cases, so 8 of 9 of them had early washout as the feature that made them go into LRM. And we had 1 benign nodule that ended up in LRM that was biopsied twice after multiple examinations. So LRM interpretation includes recommendation for biopsy or pathology proof. So when we did univariate and multivariate analysis, we found that washout greater than 60 seconds is the feature most predictive of HCC, and washout less than 60 seconds is the feature most predictive of non-HCC malignancy diagnosis. And so what we've obviously support, I believe, is that LR5 allows us confident diagnosis of HCC so that patients can be treated or transplanted without biopsy, and that LRM will detect virtually all other malignancies, both ICC and metastases, and about 1/3 of LRM in our study was HCC. So let me just show you a couple cases. I want you to yell out the answer. So this is a 74-year-old male with cirrhosis. Okay, so there's his MR scan, his pre-GAD, and then arterial portal and late phase images. So it's T1 dark, and then it's got kind of heterogeneous enhancement in the arterial phase. And then what does it do? Nothing. Pardon? It persists. Exactly. So it persists. So the scan is bothersome. So progressive enhancement in the central portion of the lesion. So here's his CUS. So he's got a big mass in his liver. And when we do our contrast scan, first of all, so what does that show you? My goodness, an absolutely wild pattern. So it's kind of got rim enhancement, but then it's got a big enhancing ball in the center. It doesn't, nothing benign for sure. And we can see now that we're looking at it, that in addition to that kind of rim enhancement, what's it starting to do? We're still very early, and it's starting to wash out, right? It's starting to go down, And so when we come to our pictures, there's our wild picture in the arterial phase showing the vascular tumor. And then by 34 seconds, weak washout, 52 more marked, and then really washed out. So what are we going to say? This is LRM, and we're going to biopsy it. So we're going to biopsy it, and this is a bit discordant with MR in my mind. Rim enhancement, rapid marked wash, discordance between CUS and MRI in the portal venous phase, non-hepatocellular malignancy for sure, and although I'm already writing the name cholangiocarcinoma, it's not. It's a B-cell lymphoma. But the thing is, you have to get that also. And so there are things about LRM. LRM will pull you into kind of a few things that won't always be what you think. So don't be so quite as aggressive with LRM, but it's malignant, and I think that's a great example of using both MR and ultrasound and determining that we should biopsy that case. So what about this great case? This is a 62-year-old male who has an unknown clinical history. And with all my questioning and investigations, I never proved that he was at risk for anything. So here's a CT scan. So what does he have? Little focus of enhancement and nothing else. So we don't know what that is, but it's concerning. So he goes from there to have more imaging. So he goes to MR scan, T1 dark nodule, T2 slightly bright, restricted diffusion on DWI. And then when we come to his GAD pictures, you can see that he has a nodule that enhances and it doesn't wash out. So this is not a risk patient. So now he comes for ultrasound. So there's his ultrasound showing a really sharply demarcated mass in his liver, and it enhances on the arterial phase. So you can see we inject the contrast. This is a hyper-enhancing mass. So hyper-enhancement, more than 2 centimeters in diameter, and by 1 minute it's gone. So this is discordance, discordance, discordance. So this patient does not have risk factors for HCC. So how do we report this? What do you think? Well, so once you start to do LIRADS and you really get involved in it, your mind wants you to call it LRM and LR5, but we're not supposed to call anything that's not in a risk patient LRM. But what this shows you, though, is that, see, we knew way before we started to do LIRADS that ultrasound and MR are discordant in cholangiocarcinoma. So I might say in my report, if this patient had risk factors for HCC, I would call this LRM, in which case I think it will be cholangiocarcinoma. And then I would say, but as this patient does not have risk factors, we're not allowed to call it LRM, but I still think it's cholangiocarcinoma. So that's what I said. And so we said that it's discordant with CT and MR, rapid mark washout, do a biopsy, and the biopsy is cholangiocarcinoma. And so even though we don't want you to put things into categories for risk for HCC, if they can't go in there, we think the same way. Those rules that are part of the LIRADS rules, they're rules that we had developed a long time ago. We knew that those things happened. And so I think that's a great case too. Now this one's a really special one. So this is a 74-year-old male who has a normal liver. He has no risk factors that we know of. And so he finds a large mass incidentally detected when he presented to the eMERGE with abdominal pain. So there's a beautiful picture for you. So a big expansive mass at the tip of his liver. And so what do we do? Of course, contrast-enhanced ultrasound. So this beautiful scan shows that he has a mass that fills from the periphery to the center. And this is a male, keep in mind, he's over 70. So it fills from the periphery to the center. And we're using a lovely bubble tracking technique right there. And so we can see those kind of dysmorphic vessels, heterogeneous enhancement, but definitely a hypervascular mass. And there's the beautiful picture we have at the peak of the arterial phase enhancement. So now what are we going to do? So now we're going to look at it. So at 90 seconds, at 1 minute it was ISO enhanced, and at 90 it might be down a little bit, but it's not enough that I'm going to say that it's gone there. I'm not going to say that for sure. Whoops. And then at 4 minutes, there's definitely washout. So what are we going to say about this? So what if this patient did have risk factors? We would say this is LR5, HCC. And so this patient doesn't have risk factors, but what are we still going to say? HCC. So that's exactly it. So arterial phase hyperenhancement with late week washout suggests HCC. And so even though the patient doesn't have risk factors, so we're not going to say this is LR5 because it's not LR5, it's not the population. He's a patient who has nothing else wrong with him, comes to our eMERGE. And so this is, and I put right in the report, this should be HCC. And so again, we can always go right out there and say we think it's HCC. And it's very helpful. I have had the surgeons say that to me often. So this patient was also biopsied just because of the circumstances. And then this was resected, and that is an HCC in a normal liver. And so they tend to look the same as HCCs elsewhere. And so what have we looked at? HCC, arterial phase hyperenhancement, usually diffuse with late week washout. LR5 non-hepatocellular malignancy will fall virtually always into that LRM kind of category, but it's got rim enhancement and rapid washout. And so I think that these are really actually great categories. So HCC and LIRADS, what do I think? Well, it really greatly improves CUS integration into multimodality imaging for nodules in at-risk patients. And LR5 allows for identification of those who may be treated or transplanted without biopsy, and LRM detects HCC, ICC, and other malignancies. These are, again, resolved by the fact that we recommend biopsy for every patient that we say we think has got LRM. And if we're doing it outside of that category, like of the LIRADS category, and we just say we think it's cholangiocarcinoma, the very next thing I put, recommend confirmation with biopsy. Thank you. Are there any questions? Yes?
How many of your patients had lymphoma?
A handful, every year a small handful. So they're uncommon, but they do come along, and most hepatic lymphoma, they're big tumors, like big things. They don't turn out to be like little tiny things. They're usually big and solitary, and they're almost all B-cell lymphomas. And in all age groups, and mostly in women. Good. Now, what are we doing?
CUS and current guidelines.
Oh, okay. So Richard will speak to us about CUS and current guidelines. Thanks, Richard.